नमस्कार डॉक्टर नलिनी. नमस्ते डॉक्टर नरसावेनी.
नमस्ते मैम. नमस्ते.
So we are live now. So we will start our session. So good evening to all of you. Good evening to all respected delegates member and faculty members who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 189th edition of Happy Learning Masterclass webinar series in association with Anantpuram, Himavaram, Guntur, Kadapa, Kurnool, Ongole, and Tirupati. So, welcome you all. And today's theme for webinar is mixed bag. Uh, the convener for today's webinar is Dr. Asha Jain ma'am. So let me introduce madam. So Dr. Asha Jain madam has very vast experience of 34 years in this field. Madam is currently director SMSA Hospital Raipur, medical director CPRS, elected member Chhattisgarh Medical Counseling, and madam has Foxy recognized ultrasound colposcopy training centers. Madam's fields of interest are saving the uterus, fetal medicine, OPS and gyne ultrasound, critical care, preventive oncology, and colposcopy. Madam is also ISCCP colposcopy trainer. So I welcome Dr. Asha Jain, madam. And as per the traditional course, we will start our session with lamp lighting ceremony. So thank you so much, all respected faculty members and delegates for your patience. Now I hand over the session to Dr. Asha Jain, ma'am. So over to you, ma'am.
Thank you, Nilesh. Namaskar, respected faculty and all delegates. This program, the Happy Learning Masterclass 189, is the brainchild of Dr. M.C. Patel, sir. He has been doing this continuously for more than 3 years. And we all know, sir, he is a very senior gynecologist, medico-legal expert, and a very approachable person, always ready to help all gynecologists. I invite Sir for his official welcome address.
Thank you, Dr. Asha. It gives me immense pleasure to welcome you all to this 189th episode of Happy Learning Masterclass web series. And today's joining society, Anantpuramu, Bhimavaram, Guntur, Kadapa, Kurnool, Ongole, and Tirupati. I welcome two guests of honor, Dr. Karuna Vidupalli Madam from Anantapuramu. She has kindly consented to be guest of honor to bless the webinar. Welcome, Madam. I also welcome Dr. Ramchandra Sir from Tirupati. He has also kindly consented to be guest of honor to bless the webinar. I also welcome today's learned speaker, Dr. Deepa Singh Mitra from Ongole. She is going to discuss very interesting topic of APH for today's webinar. And today we are going to have reverse panel on consent. Consent, does it concern or what is ideal consent in Indian consent is the topic for reverse panel, and all the learned panelists will be asking question, and being a moderator I will be answering. So I welcome all the panelists. But before that, I welcome three chairpersons who are going to chair session of Dr. Deepa Sangmitra Madam. So they are Dr. Sri Lakshmi Madam from Kurnool, Dr. T. Bharati Chandrasekhar Madam from Tirupati, and Dr. Narsavani Madam from Bhimavaram. I also welcome all the learned panelists, Dr. Samsad Begum from Anantapuramu, Dr. Sri Krishna Sasi sir from Anantapuramu, Nalini Katta Madam from Bhimavaram, Nirupama Madam from Bhimavaram, Dr. Venkateshwar Rao from Guntur, Dr. Uma Shankar from Guntur, Dr. Padmalata Yarsi Madam from Kadappa, Dr. Venkata Raman from Kurnool, Radha Lakshmi from Kurnool, Ramkrishna Hanuman from Ongole, Sri Devi Anamulla from Ongole, Parth Sarthi Reddy sir from Tirupati, Uma Devi Ralla Madam from Tirupati, and good old friend Dr. Manikya Rao from Kurnool, and Dr. K. Sunita from Tirupati. I also welcome Dr. Asha Jain, she is convener in this series since long, and two coordinator, Dr. Rekha Rajendra Kumar, President Bengaluru. She is coordinator in this series since long, and Dr. Sujay Sri from Bhimavaram. She is also one of the coordinator for today's webinar. And Sujay Sri has helped me a lot for this program, for designing and for execution of this program. So I put on record my deep sense of gratitude to Dr. Sujay Sri for all the help for this webinar. And I welcome all the president and secretary of all joining society and all the delegates. So today we are going to discuss very interesting topic of APH and reverse panel on consent. So in this series, this is of course 189th episode. When I started this series in era of COVID with three friends, and now it has become more than 7,000 plus member family as far as Happy Learning Masterclass is concerned. Goal was to meet our Foxian friends on virtual ground, to say hello, to discuss focused topic, and to brush up our knowledge. And still this series is continued with all the efforts on part of all the friends and blessings of senior. So without wasting much of your time, welcoming you all to this 189th episode of Happy Learning. Thank you very much.
Thank you, sir. Thank you so much. With due permission, we would like to start the inauguration ceremony.
Oh, yes.
So, before we start the inauguration, I would like to introduce both our coordinators. Sir, just a second. Just a second.
Sir, namaste.
Namaste, namaste. Very busy with your incoming conference?
Yes, sir, lot of program. I'm doing 30th program.
Because the link was not working, sir, so we are having a problem. So people are calling that
Yes.
first link did not work.
Yeah.
So, may I have the CV of Dr. Rekha and Dr. Sujayshri, please? So Dr. Rekha doesn't really need an introduction. She is the current president of Bangalore Society, a really very, very big society with a lot of work. She's a practicing gynecologist for 32 years and is an invited faculty in more than 750 state, national, and international conferences. She has immense work and she's been associated in this webinar for a long time. May I have Sujaya, please? So Dr. Sujayshri is very well known and especially one of her society is part of this webinar. So she is a consultant at Seshadri Hospital, Palakol and Malkipuram. She has Shan S. Ratnam Young Gynecologist Award. She does a lot of community work and she is a laparoscopic surgeon and an IVF specialist. So welcome, Dr. Sujayshri. May I have the CV of our first guest of honor? Requesting Rekha ma'am, would you please introduce Aruna ma'am?
Yeah, thank you, Dr. Asha Madam, for giving me this opportunity. And again, thanks to MC Patel sir for his immense support, blessings, and involving us in all his programs throughout. It's my proud privilege to introduce Dr. Aruna Bidupalli Madam. Madam, I have contacted you many times before also, you may not remember. But anyway, it's again nice time to get connected to you. Madam is MBBS from Andhra Medical College, Andhra University in Visakhapatnam. Her MD-DGO is from our Karnataka, that is Davangere. She's trained in laparoscopic surgery, running super specialty hospital by name Snehalata Hospitals in Anantapuram since last 28 years. Madam is a managing director of Snehalata Hospitals, Anantapur Obstetrics Gynecological Society in Anantapuram. Madam has taken a lot of key positions in many of her events. And Madam, we welcome you and we would like to hear from you. Thanks for accepting our invitation as guest of honor. I had come to your hospital also, Madam, with the Dr. B. Ramesh for program.
Yeah, you came.
Yes, Madam. Yeah. Please proceed. We would like to hear from you.
Okay. Thank you, Madam, for the nice introduction. And thank you for inviting me as a guest of honor for this webinar session. Thank you, Dr. Patel, sir, and wish you all the best for the coming elections.
Thank you.
I thank Dr. Asha Jain, convener, Rekha Rajendra Kumar, and Ritu Khanna on arranging for this nice program and for including our society also in this program. The topic you have selected is very useful one, APH and legal issues in labor and sudden obstetric collapse. I think nobody can understand the obstetrician problems attending the case, except the obstetrician who is attending the case. We have to defend ourselves. The consent taking and documentation are so important nowadays, and legal issues are dominating our profession, and it is giving big tension and headache rather than the professional tensions. Documentation became important rather than attending the emergency cases. I think so. So wish you all the best for the webinar you are conducting. All the best.
Thank you. Thank you, madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you.
Thank you, Aruna Madam, for your blessings.
Yes.
Thank you so much, ma'am. May I request Dr. Sujayashree to please introduce Dr. Ramchandra, sir?
Yeah. Thank you for that very warm introduction, Dr. Asha, ma'am. She is a very good a mentor, someone I look forward to. So thanks, ma'am. And I would like to thank Sir MC Patel, sir, for this opportunity. So moving on, I would like to introduce our guest of honor, Dr. K. Ramchandra, sir. He's a consultant gynecologist, laparoscopic surgeon, and IVF specialist at Manohari Super Specialty Hospital and IVF Center at Tirupati. He was formerly the professor and associate professor at Shantiram Medical College, Nandyal, AP. He's also been the assistant professor at the Government Medical College, senior resident at JIPMER Pondicherry, junior resident at AIIMS New Delhi, and the ex-IMA president of Tirupati. So very warm welcome to this program, sir.
Is he there? I don't see.
Yeah.
No issue. We can proceed further, and we will have his blessings when he joins.
Yeah, whenever he joins us, we can take his blessings.
Oh, yes, we can proceed.
So, Jia, would you go ahead and introduce the chairpersons?
Yeah, sure, ma'am. Moving on. So the chairpersons for today's session are, we have Dr. Sri Lakshmi Ambakar ma'am with us. She's a professor and head of the department, Kurnool Medical College. She is a PG teacher and examiner in various universities since 26 years. She has been a guest speaker in many CMEs and state conferences. She's published many papers in national and international journals. And awards and accomplishments to her credit, she has received a gold medal in Millennium contest in the year 2000. She has also won the first prize for Foxy ICOG National Conference in the year of 2021. She has received a Best Doctor Award Her field of interest currently are high-risk pregnancy and preventive oncology. A very warm welcome, ma'am, to today's session. Moving on, we have Dr. T. Bharati with us. Madam is the medical superintendent in the government hospital of AP in Tirupati. A warm welcome, madam. We have Dr. Naswani Sunkara. Ma'am is very well known to us because she's from our society. So we all look up to ma'am. So she's like a mentor for the entire society. So ma'am is currently the vice president of the Bhimavaram OB-GYN Society, a consultant at SVR Maternity Hospital, Bhimavaram. She has an experience of 24 years in OB-GYN, and her areas of interest are high-risk pregnancies, PIH, ectopic pregnancy. A very warm welcome to Dr. Naswani. So I request one of you to please introduce the speaker for today. Would one of the chairpersons please introduce the speaker?
Chairperson,
Dr.
please.
Deepa. Yeah, Dr. Deepa Sangamitra. Yeah. Ma'am, Dr. Naswani, would you like to introduce her, ma'am? Are you there with us?
Okay.
Yeah, please go
Yes,
ahead, ma'am.
First of all, I should thank Dr. Asha Jain ma'am and also MC Patel sir for involving this in this program. And thank you, sir, and thank you, ma'am. And I am going to introduce our guest speaker, Dr. Deepa Sangamitra, who is did her MBBS from Coimbatore Medical College, 1995 to 2001, and DCO from Madras Medical College, 2002 to 2004, and DNB from GKNM Hospital, Coimbatore, 2006 to 2008, and board medalist in MBBS for Obs and Gynec in 2000. Awarded the Bhaskar Rao Gold Medal for the year 2008 by the National Board of Examinations in New Delhi. Earlier worked as consultant gynecologist in Sundaram Medical College Foundation, Chennai, and as an assistant professor in Anna Medical College, Mangalagiri. She has been associated with Aster Ramesh Hospital, Ongole since 2011, and she has special interest in high-risk pregnancy and gynec endoscopy, and has numerous papers presented in publications in national conferences. Over to you, ma'am.
Good evening, all of you. Am I audible? Am I audible?
Yes, ma'am, you're audible. Very much audible.
Yeah. Good evening, all of you. Thank you all for having me here. I can see so many senior gynecologists here. So I'm extremely humbled that I have been invited as a speaker for this session. And I hope I will be able to do justice to all of you. I'll just share my screen. Just give me a minute.
You have shared your screen. Please make it a full screen. That's all. Yeah, thank you.
Today, the focus is on antepartum hemorrhage, a practical approach to its evaluation and management. So as we all know, antepartum hemorrhage is one of the most dreaded complications during pregnancy. It's a complication that we would rather not want to encounter because it is responsible for almost 35% of maternal deaths. It's one of the most important and leading causes of direct maternal deaths. And not only that, it is also responsible for considerable adverse perinatal outcomes too. And the problem doesn't stop there. It leads to PPH in quite a few cases. So that is why it is very important that we all have a thorough knowledge of what APH is, how to diagnose it, how to evaluate it, and also how to manage it. So incidence of APH is 2 to 5% of all deliveries. And APH, as I already told you, can cause maternal and fetal problems. The maternal problems include preterm delivery, preterm premature rupture of membranes, malpresentations, anemia, sepsis, increased operative deliveries, PPH, consumption coagulopathy, renal tubular necrosis, shock, prolonged hospital stay, and last but not the least, it can cause a significant amount of psychological sequelae in the mother, which she can carry to long term. Now coming to fetal complications, the most important being prematurity, which can either be iatrogenic or spontaneous, fetal growth restriction, birth asphyxia, and intrauterine fetal demise. These are all the problems. So traditionally, antepartum fetal hemorrhage has been defined as bleeding that occurs from or within the genital tract any time after 20 weeks of gestation and before the delivery of the baby. So this is the ACOG definition, but the RCOG keeps the gestational age cutoff as 24 weeks of gestation and not 20 weeks. So we, being a developing country like India, I think we can also go by the cutoff of 24 weeks rather than 20 weeks. Now, causes of antepartum hemorrhage include bleeding from the uterine and vaginal walls or cervix, placentation-related bleeding, or sometimes if we are not able to find a cause, we can group it as unexplained antepartum hemorrhage. So among these, the placentation-related bleeding is what we are worried about. It is of concern, and that only mandates immediate evaluation. So coming to the causes a little bit in detail, when we come to causes in the genital tract that can cause APH, the first thing is show, bloody discharge, which can be mistaken as APH. It is nothing but show, which indicates the onset, signals the onset of labor. Bleeding can also occur from cervical lesions like erosions, ectropions, polyps, or rarely cancer also. Trauma to the genital tract can cause bleeding, presenting as APH. Vulvovaginal varicosities can cause bleeding. Genital tract tumors, genital infections, condylomas, etc. Sometimes even hematuria may mistakenly present as APH, may be mistaken for APH. Now, coming to placental site-related antepartum hemorrhage, we have the three important causes: placenta previa, abruptio placenta, marginal sinus rupture, and another one which is related to the cord insertion called vasa previa. Now, coming to the important placentation-related APH, abruptio placentae, which contributes to 0.5 to 1% of deliveries, placenta previa 0.3 to 0.5%, and vasa previa, which happens in less than 0.1% of cases. So abruption means bleeding that occurs from a separation of a normally located placenta occurring anytime after 20 weeks and before delivery. So types of in abruption, we have concealed, revealed, and the mixed types. Placenta previa means bleeding that occurs from a placenta that is implanted in the lower uterine segment. So why does the placenta that is implanted in the lower uterine segment alone needs to bleed and not the one in the upper uterine segment? That's because, as we all know, in the second half of pregnancy, as the uterus stretches, the enlargement happens differentially in the lower uterine segment more than the upper uterine segment. So the lower uterine segment tends to stretch more. So because of that growing stretch of the uterus or the cervix, the placenta that is implanted in the lower uterine segment thereby tends to bleed more than that in the upper uterine segment. Bleeding can also occur due to uterine activity. The rarest of all is the vasa previa. In vasa previa, what happens is there is a velamentous cord insertion. So the umbilical vessels in the umbilical cord, instead of directly inserting into the placenta, they traverse through the membranes to a certain distance before inserting into the placenta. So as they traverse through the membranes, in case this part is overlying the os, and when the patient gets into labor, as the cervix dilates and the membranes rupture, the part of the membranes that is directly over the os, if it has the vessels traversing through it, as the membranes rupture, the vessels also will rupture, isn't it? So now where does the bleeding come from? The bleeding is coming from the vessels of the umbilical cord. That is, the bleeding is happening from the fetal side. And that is why this kind of bleeding is very dangerous, because it's going to exsanguinate the fetus very soon. And the diagnosis of vasa previa is mostly made intrapartum when the patient is in labor. So this is placenta previa, the three types. The first one is the marginal, the second one is the complete, and the third one is partial previa, where it is partially covering the os. And this is abruptio placenta, the first one being totally concealed kind of abruption, the second one being the revealed abruption, and the third one being the mixed type, where you see both an RP clot and bleeding coming outside. And this is vasa previa. You can see the umbilical vessels, they are traveling through the membranes and not directly inserting into the cord. So when this part of the placenta is lying over the cervix, these vessels will bleed and cause fetal exsanguination. What is the clinical presentation in a patient of APH? Any patient beyond the gestational age of 20 weeks, if she presents with bleeding PV of any severity, we call it as antepartum hemorrhage. And in case this happens on more than one occasion, then it is called recurrent antepartum hemorrhage. So when such a patient comes to the labor room or to the emergency room, our goal of clinical assessment is to establish whether we need to do an urgent intervention, either to manage maternal compromise or fetal compromise, whether any one of these is present. So our triage process will include a proper history taking so that we can look for coexisting symptoms, which will give a clue as to the diagnosis of APH, assess the extent of bleeding, assess the cardiovascular status of the mother, and then the fetal well-being also. So what do we look for? In the history, we have to ask whether the bleeding is painful or painless. If at all there is pain, whether the pain is continuous or intermittent. We have to visualize and estimate the amount of bleeding. So, but this may not be a very accurate estimate, especially in patients with abruption. We tend to grossly underestimate the amount of bleeding that is happening. So in addition to visually estimating the amount of bleeding, we also assess the hemodynamic status of the mother, which will give us a better idea of what exactly is happening. We look for the 3S: sweating, syncope, and altered sensorium. If any of these are present, it indicates that the patient is having a massive hemorrhage. Then we check for the fetal well-being and gestational age. We look for whether any obvious risk factors are there for the antepartum hemorrhage. Then we do an obstetric examination to identify the source of bleed so as to plan the management accordingly. And lab and ultrasound assessments are other useful adjuncts. So what are the risk factors for antepartum hemorrhage? Looking at the two major significant causes, if we see abruptio placenta risk factors and placenta previa risk factors, we can see in this table itself that most of the causes are overlapping. The single most risk factor for antepartum hemorrhage, either an abruptio placenta or a placenta previa, is the history of an abruption in the previous pregnancy or a history of a placenta previa in the previous pregnancy. In such case, the chance that the patient will have a recurrent abruption or recurrent placenta previa is several-fold, 3 to 4-fold higher. Presence of PIH and fetal growth restriction is a risk factor for abruptio placenta. ART pregnancies, there's a higher chance of abruption. PROM can cause abruption, trauma can cause abruption, polyhydramnios, malpresentations can cause abruption. Multigravidas are more likely to have abruption than primigravidae. Advanced maternal age, low BMI, smoking, drug abuse during pregnancy can all cause abruptio placentae. Placenta previa is an important risk factor for abruption. Fibroid uterus, uterine infections, and anomalies can also cause abruptio placenta. Now coming to placenta previa, in addition to previous previa being a risk factor, multiple pregnancies are more likely to have placenta previa. Obviously, because the surface area of placenta is larger, therefore it will occupy a more place and likely to encroach into the lower uterine segment. Then a placenta that is implanted over a previous cesarean section or implanted in a scar endometrium can also likely to be previa. Scarred endometrium again could be because of previous infections or manual removal or curettage or anything of that sort. So in all these patients also, because the placenta, it's not deriving adequate vascular supply from all these unhealthy areas, it tends to occupy a larger surface area and thereby encroach into the lower uterine segment. Then ART pregnancies can have placenta previa, multiparity, placenta previa, advanced maternal age, smoking, submucous fibroids, and anomalies. All these patients can have placenta previa as well. So in APH, how do we assess the blood loss? We look for the 4 P's. We see if the patient has pain, pallor, we check her pulse and her blood pressure. If the bleeding is very minimal or fresh bleeding, or if it is a bloodstained discharge, then it is show, probably. If there is intermittent spotting of bleeding, then it could be local lesions like polyps of cervicitis, very rarely cancer. So in such patients, it's important to we should never underestimate a speculum examination in these patients. A speculum examination will help us to identify local lesions and they can be treated appropriately. Speculum examination will also identify if the cervix is dilated or not, because especially in placenta previa cases, and unless we do a scan and rule out placenta previa, we are not supposed to do a digital examination in these patients. So a dilated cervix can also be picked up in a speculum examination. If the bleeding is significantly heavy, then we will narrow down our diagnosis to only 2 causes, abruptio placenta or placenta previa. Now, based on the way these patients present, based upon the clinical presentation, again, we can diagnose whether it is abruption or placenta previa or vasa previa. Abruptio placenta can present either antepartum or intrapartum. Bleeding is most often painful. Necessarily, bleeding need not be there in all cases. It may be completely concealed also. But in all patients with abruption, the uterus is tense and tender. And maternal complications, severe maternal complications like DIC and renal failure are seen only in abruptio placenta. Now, placenta previa, present antepartum, the bleeding is more often than not painless unless the patient is in labor. And bleeding is always the rule. You cannot have a concealed bleeding in placenta previa. Uterus is mostly relaxed. Very rarely, it may be acting if the patient is in labor. And initial episodes of placenta previa, the episodes are usually self-limiting. Vasa previa, as I already told you, painless bleeding, fetal bleeding associated with rupture of membranes and causing fetal bradycardia and fetal demise. So elaborating each one, placenta previa, presence with recurrent episodes. Initial episodes are usually self-limiting. The bleeding stops within 1 to 12 hours. And the incidence of low-lying placenta, it varies widely from what it was in the first trimester to what is it in the mid-trimester and at term. So though we have a 42% case of low-lying placenta at 11 to 14 weeks, at 24 weeks, it is only 4 to 5%. And by the time the patient reaches term, it is only 1%. This happens because of placental migration. And why does migration occur? Due to trophotropism. Trophotropism means the tendency of the placenta is to naturally grow in areas where it gets good nutrition and perfusion, and thereby it moves upwards. And the movement happens at a rate of 1 millimeter per week. But do all placentae that are implanted in the lower uterine segment migrate? No, usually the ones that do not migrate are the ones that are implanted on the posterior wall, the ones that are attached to a myomectomy scar or a cesarean section scar, placentae that are directly implanted over the internal os, or when the angle in between the placental edge and uterine wall is less than 135 degrees, such placentae do not migrate. Coming to the clinical presentation of abruptio placenta. The classical triad in case of an abruptio placenta is pain, uterine tenderness, and bleeding. If it's a posterior placenta that is undergoing abruption, the patient has backache, typically complaints of backache. Pain and bleeding is present in 80% of cases, while in 50% of cases, we also have evidence of fetal distress and bloodstained liver. Why does pain happen in abruptio placenta? Because the blood accumulates in the retroplacental region, and this accumulation of blood causes uterine distension and pain. And why does a tense and tender uterus come in a abruptio placenta? Because as the blood accumulates retroplacentally, some of it also seeps in between the myometrial fibers, and this intramyometrial blood accumulation causes the uterus to become tense and tender. Clinical assessment of blood loss in all these cases is grossly inaccurate, especially if it's a concealed type of abruption. Abruption is fraught with both maternal and fetal complications. In fetus, it is either fetal distress or demise, while in the mother, it is coagulation disorder or renal failure. So why does coagulation disorder come in abruptio placenta? When the placenta shears itself off from its attachment, there is a release of thromboplastin that happens in the retroplacental area. This thromboplastin will enter into the maternal circulation and activate a coagulation cascade, thereby causing consumption coagulopathy. And because of the severe bleeding that she's having, that volume depletion is severe enough to cause renal hypoperfusion. Renal hypoperfusion will naturally, the patient will land up in acute renal failure, which is reversible in most of the cases. Now, vasa previa. In vasa previa, the triad is painless bleeding, rupture of membranes, fetal bradycardia. And because the fetus is exsanguinating, on CTG, we see the typical sinusoidal pattern. Vasa previa, very rarely, it is picked up on color Doppler imaging antenatally. Experts can pick it up. Here we can clearly see that the fetal head is there, and then these vessels coursing through the membranes as they go directly over the cervical os. This is how a vasa previa looks on color Doppler imaging. Coming to the role of ultrasound in antepartum hemorrhage. Now, for evaluation of placenta previa, ultrasound is a gold standard. And specifically speaking, transvaginal ultrasound is a gold standard because transabdominal ultrasound can overestimate placenta previa by almost 25% chance. On the other hand, a transvaginal ultrasound has an 88% sensitivity, 99% specificity, 95% positive predictive value, and 98% negative predictive value. Traditionally, we know that placenta previa is classified as complete, partial, or marginal. But this new classification based upon the transvaginal ultrasound measurements will help us to guide delivery planning. So because this is used as a guide to plan delivery, this classification is done only when we do a transvaginal ultrasound within 28 days of term. That is, the scanning should be done between 33 to 37 weeks. And based upon how much distance is there between the placental edge and internal os, we classify placenta previa into type 1, 2, 3, and 4. When the distance is more than 20 millimeters away, it is type 1 previa, where invariably cesarean section is not indicated because it's less likely to bleed. Type 2 previa, 11 to 20 millimeters away, actually the opinion is divided, though the books say less chance of bleed and less need for cesarean sections. But anything within 20 millimeters, it is better to plan a cesarean section. When it is between 0 to 10 mm away or any overlap of internal os, that is in type 3 and type 4, there is a higher chance of bleed, and therefore cesarean section is the rule in these cases. Now coming to ultrasound features of placenta accreta spectrum. Placenta accreta spectrum, morbidly adherent placenta, we have accreta, increta, or percreta based on whether they are adherent to the endometrium, myometrium, or whether they are invading the serosa also. And they again can be subclassified as focal, partial, or total, based on whether the adherence is focal, partial, or total. So all placenta previa must be evaluated for morbid adherence. And what do we look for in the scan? We look for increased vascularity on Doppler. And there is a hypoechoic zone, a boundary that we see in between the placenta and the uterine wall. That hypoechoic boundary between the placenta and uterine wall and the myometrium is usually lost. Absence of the subplacental sonolucent zone. Presence of lacunae within the placenta, it has the highest sensitivity for diagnosis of placenta accreta. So these are all the findings that we should suspect placenta accreta, and confirmation is done using an MRI. This is again an image of how a placenta, morbidly adherent placenta looks like. Now coming to the role of abruption, the role of ultrasound in abruption. Ultrasound has limited efficacy compared to placenta previa in diagnosis. But there are certain signs which we pick up in which we pick up on ultrasound. If it is present, then the diagnosis of abruption is almost certain. They include the presence of an RP clot or a hematoma, an area of poor echogenicity beneath the placenta. And here there is something called a Jello sign, where we just apply pressure with the transducer over the placenta. And because the placenta has separated itself, the placenta will kind of move when we apply the pressure on the transducer. The placenta will jiggle rather. Now, a loss of angularity and placental edge separation is another feature. Thickening of the placenta, more than 5.5 centimeters. Intraplacental blood pools, anechoic areas within the placenta. Opacities in the amniotic fluid, which indicates hemorrhage or blood-stained liquor. Fetal stomach bubble also may show clouding, indicating the fetus has swallowed the blood-stained liquor. Thickened retroplacental myometrium. Disrupted retroplacental circulation, which we pick up on Doppler assessment. This is how a typical abruption picture looks like. Here, a posteriorly implanted placenta, you can see a large retroplacental clot shearing off the placenta, lifting off the placenta in entirety. Now, classification of abruption. Unlike classification of placenta previa, which was based on ultrasound, classification of abruption is based on clinical features. And placenta previa is classified as types. Abruption is classified as grades. Grade 0 abruption, where there are no clinical features. We make a diagnosis of abruption only after delivery, where we see the RP clot, and then we realize, this patient had an abruption. Grade 1, where the bleeding is mild, the uterus is tense and tender, but both the maternal well-being and fetal well-being are maintained. Grade 2, where the bleeding is moderate, the uterus is tense and tender, there is no maternal shock, but there is obvious evidence of fetal distress. And grade 3, where the bleeding is very heavy, severe, invariably there is fetal demise, uterine tenderness is marked, puvilla uterus also comes under grade 3, maternal shock is present, DIC and anuria may also be present. Now, volumetric assessment of blood loss can also be made through sonography. How? By measuring the size of the hematoma. Once we measure the size of the hematoma, the length into width into height in millimeters divided by 2 will give the volume of blood within the hematoma. And volumes larger than 500 ml and placental detachment of more than 50% is associated with adverse perinatal outcomes. So this is a very accurate predictor of how the pregnancy outcome is going to be. When there is a blood loss of more than 2.5 liters, fetal demise is almost the rule. So this is clinical evaluation. Now coming to the lab parameters, we ask for a complete blood count, blood group type and cross match. Coagulation studies like PT, APTT, fibrinogen levels, FDP, D-dimer, these are all tests that are done if an abruption is suspected, or massive hemorrhage, liver function test, renal function tests. An elevated LDH levels and schistocytes on the peripheral smear will indicate presence of intravascular hemolysis, which is a feature of HELLP syndrome, which may cause abruption. Now, viral markers are also done. And coming to the management of the patient. So management includes immediate resuscitation and hemodynamic stabilization. If conservative management is feasible in mild cases, we can do it. Otherwise, we have to plan the mode of delivery and followed by postpartum care. Resuscitation of the patient includes first rapidly assessing the maternal and fetal condition. We secure 2 large bore IV access. We resuscitate the patient using both IV crystalloids and colloids, commonly used RL and Hemaxel, first fluids of choice. An indwelling Foley's catheter is placed to record the output. We have to maintain the urine output at or above 30 ml per hour. At the same time, we should also avoid injudicious use of fluids because volume overload may happen and result in pulmonary edema. This especially, we have to be very cautious in cases of preeclampsia, because preeclampsia is one condition where abruption also comes. We should not overload the patient. We have to continuously monitor the vital signs. We have to arrange blood and components. And if the blood loss is suspected to be more than 1000 ml, then we initiate massive transfusion protocol. Clinical assessment of blood loss is based upon, the patient is classified into class 1, 2, 3, or 4 based upon the amount of blood that is lost. If the blood loss depletion is up to 15% of her blood volume, she comes under class 1. If it is 40% or more, she comes under class 4. This is the patient is classified based upon her vital parameters and the tissue perfusion signs. Now, OSI, it is a rapid method by which we can assess the amount of blood loss that is happening. This is a simple calculation. We just divide the patient's heart rate by her systolic blood pressure. Normal OSI, obstetric shock index, levels should be 0.7 to 0.9. Anything more than 1, it predicts the need for blood and component therapy. It is one of the earlier marker of maternal jeopardy than the vital signs. So if we have confirmed that our patient is having massive hemorrhage, she's hemorrhaging profusely, and we've initiated massive blood transfusion protocol, we have to follow the rule of 4. Rule of 4 means we arrange for 4 platelets, 4 cryoprecipitates, 4 FFP, and 4 PRBC. The ratio of FFP to PRBC transfusion is usually 1:1 or 1:2. So we have secured 2 broad IV axes. So one through which we give PRBC, and the other line we use to transfuse FFP, cryoprecipitates, and platelets. Our goal should be to keep the hemoglobin at 8 to 9 gram per deciliter, platelets above 75,000 per ml, and maintain PT-APTT levels at less than 1.5 times the control. Continuing management would be the patient should be kept warm to prevent hypothermia. She must be transferred to a high dependency unit or an ICU. And in case delivery is contemplated, we should immediately inform the OT, anesthetists, neonatologists, and keep them ready. It's always nice to include senior colleagues in our management because they are very experienced and they can help us out in such critical cases. And while doing all this, we must also remember that we should keep the patient attenders in the loop. Counseling is very, very important. We have to explain to them in detail about what is going on with the patient, the diagnosis, the plan of management, what all complications may occur in the mother, the chance of DIC, renal failure, need for ICU stay for the mother, the gestational age, suppose the baby is premature, the chance that the baby is likely to be born premature, the need for NICU stay, and the need for blood and component therapy, and what are the complications that can arise as a result of massive blood transfusion. All these things must be explained to them in detail, and a high-risk consent must be obtained from them in writing in a language that they can understand, so that we don't have any medical legal problems in the future. So based upon the gestational age, if the gestational age is less than 24 weeks and the patient is hemorrhaging massively, we have to terminate the pregnancy. If the bleeding is self-limiting, then we can think of a conservative or expectant management. So if the gestational age is between 28 to 34 weeks, then we give a steroid prophylaxis for lung maturity, magnesium sulfate prophylaxis for fetal neuroprotection, and then plan a conservative management if the bleeding is mild or self-limited. If the bleeding is due to a small, consolidating RP clot, mostly if it's a marginal sinus rupture, etc. Otherwise, in abruption, there is usually no place for conservative management. If it's a very small consolidating RP clot as a marginal sinus rupture, and the gestational age also is less than 34 weeks, we can do a conservative management. So this conservative management, especially being what is being done for placenta previa, it is called McAfee expectant regime. The goal in these cases is to improve neonatal survival. We keep the mother and the fetus under close observation for at least 48 to 72 hours, and then think of an outpatient management if possible. And the role of tocolytics in this case, it is only used so as to allow the steroid to take effect for the initial 48 to 72 hours. After that, there is no role for tocolytics. And if the patient has any anemia, we can use this time to correct anemia if it is present. And last but not the least, if it is an Rh negative mother, we have to give her an anti-D injection, irrespective of the fact that we have given her an antepartum anti-D at 28 weeks. We have to give an anti-D again if she is having an episode of antepartum hemorrhage. The mode of delivery in cases of placenta previa, if the edge is more than 20 millimeter away from the os, we can attempt vaginal delivery if the lie is stable. And in cases where we do conservative management, we can wait for the spontaneous onset of labor. If it's within 20 millimeters from os, it is a cesarean section, which is planned after 38 weeks, unless the patient presents with a heavy episode that necessitates earlier delivery. In an abruption, the goal is to deliver the patient within 8 to 12 hours of the onset of abruption. Vaginal delivery is done only if the cervix is favorable. Delivery is possible within 4 to 6 hours, or if it is a dead, non-salvageable fetus. In all these cases, ARM helps because it decreases the intrauterine pressure, the thromboplastin backflow, and chances of DIC. Oxytocin can be used to augment labor, prophylactic forceps in the second stage to shorten the second stage, active management of third stage to prevent PPH. LSCS is done when there is fetal distress, maternal instability, or a poor Bishop score. So in all these cases of APH, we have to beware of PPH. So we have to foresee the need for uterotonics and be prepared for stepwise devascularization and hysterectomy if needed. And in cubular uterus, again, these cases are more prone for PPH, but not necessarily hysterectomy in all cases. Now coming to management of placenta accreta spectrum. These cases, as we all know, they are notorious to cause torrential bleeding intraoperatively. So management of these cases needs very meticulous planning. We have to have a team approach. So delivery of these cases is better done in a well-equipped facility. And delivery of these cases is usually planned at 34 to 35 completed weeks, because we don't want to these cases coming in as an emergency when we are not fully prepared with all the help that we need. And as a standard in placenta accreta spectrum cases, cesarean hysterectomy is done, which is accepted worldwide. But nowadays, in the last 2 decades, interventional radiology is coming up in a big way. So conservative management strategies like uterine artery embolization has helped minimize a lot of blood loss during delivery. It has even helped in fertility preservation in many cases. So there are multiple articles published both in our country and internationally all over the world about the utility of prophylactic uterine artery embolization in these cases as to how they can help in minimizing blood loss and preserve fertility also. So, but in case we are going for a hysterectomy, the hysterectomy is best done with the placenta in situ because it minimizes blood loss. General anesthesia is preferred modality of anesthesia rather than giving spinal and then hastily converting it to general. And a midline incision is preferred because we have better access to the upper uterine segment where we should place our incision. So this is one case where we can, which we did here, where we can see the placenta completely. It is almost completely invaded the myometrium, and only serosa is here. So in this case, actually, we had to cut through the placenta and deliver because we could not access the upper uterine segment. And you can see how the bleeding is a torrential bleeding. And if we are not ready with blood and components in such cases, we may have the patient exsanguinating and even an on-table death in such cases. So we have to be very quick in all these cases, rapidly try and secure hemostasis so that we can try and minimize the blood loss as much as possible. So it was a morbidly adherent placenta only. So for this case, we had to go in for a hysterectomy only. But apart from cutting through the placenta, after that, we have not tried attempted removing the placenta, and we went in with an in situ hysterectomy only. And this is another case that was done in a hospital. As a routine, we do uterine artery embolizations in a hospital for both gravid and non-gravid cases. So this patient presented to us. She was a third gravida actually, with history of 2 previous cesarean sections, with very short interpregnancy intervals, and she presented at around 30 weeks of gestation. And she presented for the first time to our emergency room at 30 weeks gestation with an episode of significant heavy bleeding. So on taking her history, she said that right from the first trimester itself, she has been having repeated episodes of bleeding PV. And on TIFA, they diagnosed that she had a central placenta previa with possible morbid adherence. So she went in for an MRI, and morbidly adherent placenta was also confirmed. And she landed in our hospital at 30 weeks gestation with an episode of very heavy bleeding. She had a hemoglobin done about 2 weeks earlier, which showed about 10.3 or 10.4 grams. But when she came to our hospital and we did a hemoglobin test, it was 7.2. So that was the amount of hemorrhage that she experienced in that sitting. And when we did a scan in the ER, we saw that the cardiac activity was absent. So she had an intrauterine demise also, and the hemorrhage also was ongoing. So we had to plan her delivery. So this patient, we took her for a prophylactic uterine artery embolization. She was shifted to the cath lab. 1 unit of blood was given in the ER and then shifted to the cath lab. So in the cath lab, the femoral artery was cannulated, and through the femoral artery, the guide wire was passed to the internal iliac artery. And once the internal iliac artery was reached, from there, another microcatheter has been passed. This microcatheter, you can see, it has negotiated all the way up to the uterine vessels. This is a uterine vessel on the right side, and the contrast is injected to make sure that we are within the uterine vessels. So once the uterine vessels were identified, polyvinyl alcohol particles were then injected through the uterine vessels so as to completely occlude the uterine circulation. So after this was done on the right side, through the same femoral artery entry, the left side also was cannulated. Yeah, the left side also was, the left side internal iliac vessels were also reached, and the left side internal iliac artery vessels also reached. You can clearly see the uterine vessels here. As the contract is being injected, you can see the caliber of the uterine vessels. So once the right uterine vessels were also identified, yeah, the microcatheter is now gone all the way up to the uterine vessels. The uterines were confirmed, and once the uterine vessels placement was confirmed, polyvinyl alcohol particles were injected into the right side also. So by effectively, they could occlude both the uterine vessels. Now this is a post-embolization contrast injection. Here you can see that the contrast is being injected, and you can hardly see any blood here. It will not be complete absence of circulation because you have collaterals and all that, but you can see that the amount of the considerable amount of blanching has taken place. So all this is dye within the bladder and dye within the ureter, but this is where we can see that the pelvic vasculature has been occluded, the uterine vasculature has been occluded to a considerable degree. So after doing this prophylactic bilateral uterine artery embolization, we then shifted the patient to the theater, and then in the theater, this was a finding. You can see that this is also a placenta, morbidly adherent placenta only, but compared to the previous picture, the vascularity is much lesser, because we managed to occlude both the uterine vessels. Now we could comfortably give an incision in the upper uterine segment and deliver the fetus. After the fetus was delivered, we went ahead with the hysterectomy. And remarkably, we did not need to use a single unit of blood also, either intraoperatively or postoperatively. So the only unit of blood that we used was what we gave in the emergency room. So this is the advantage of how a prophylactic uterine artery embolization can work in these cases. So this was what we did. But if you see the articles that were published all over the world, what they have done is, even if it's a viable baby, after separating the baby, they have tied the cord, left the placenta completely in situ, or they have attempted removing the placenta. So in some of the cases, they've managed to remove the placenta completely, though it was partially adherent. Whereas in cases where they could not remove completely also, they've left behind a bit of placenta, or even the total placenta they've left behind and sutured the uterus. And then post-operatively, they have waited for as long as 5 to 6 weeks for the placenta to detach itself from the myometrium and expel on its own. And this has happened in almost 65 to 70% of cases without any trouble. And in those cases in where it wasn't expelled, in about 20 to 25 cases, then they have taken the patient for a second sitting surgery. So these were the findings that the studies have all shown. So it is possible for us to not do a hysterectomy, just leave the placenta there and come out also. But we could not do that in this case. One thing, because the patient was not willing for it, we could not get the patient acceptance. And also, we also were reluctant because we were worried about sepsis and whether the patient will come for proper follow-up. And also, we went ahead and did a hysterectomy in this patient. So this is our experience. But in contrast to uterine artery embolization that we do for fibroids or we do for AV malformations, the caliber of vessels in case of a gravid uterus on either sides is much, much more. And the amount of polyvinyl alcohol particles that are needed are also much, much more. So it's not technically easy to do a uterine artery embolization in these cases. So now coming to postpartum care, in any APH, fluid therapy must be done appropriately. We have to correct anemia and DIC. Be vigilant for PPH in the first 24 to 36 hours. Monitor urine output properly and titrate intake also accordingly. Prevent sepsis by giving a broad spectrum antibiotics. And again, not forget injection anti-D postpartum in cases where we have spared the uterus, that is. So I would like to conclude my talk by saying that we cannot predict or prevent APH, but in all cases where there are risk factors, we have to anticipate APH and be ready. And management of these cases is driven by both maternal condition and gestational age. Thank you all for your patient listening.
Thank you, Dr. Deepti. That was a very informative talk. I request Dr. Bharti, ma'am, to please offer her concluding remarks, and then I request Dr. Sri Lakshmi, ma'am, to also add something.
Good evening. I'm
Very
Dr.
good
Bharti.
evening.
Yes, ma'am.
Very extensive and clear-cut presentation, but because it is a vast subject, both she has covered all the three: abruption, placenta previa, and also the placenta accreta also. And the other thing is about the assessment of blood loss. There are certain formulas are there, and also the definition also was changed for postpartum hemorrhage. Of course, this is only obstetric hemorrhage antepartum. So that those are the things in new Williams. So this assessment also, if practically everybody will do it, we can have some experience, because that will help for both the postgraduates and as well as the patient, how much blood we have to give, and that crystalloids mainly to give. All those are included in the presentation. It is a very good presentation, and thank you for giving me this opportunity.
Thank you so much, ma'am. Thank you so much.
I now request Dr. Sri Lakshmi to please add a few remarks. Dr. Sri Lakshmi, ma'am. Yeah, I think we'll move ahead. Thank you so much, Dr. Deepti. It was a very great talk.
Thank you.
So
Thank you.
I request Dr.
Madam,
Asha, ma'am, please. Yeah.
One thing, can I know the cost for embolization, uterine vessels embolization? How much is it a private sector or a government sector?
Ma'am, I work in a private sector, ma'am, and the cost in a hospital varies from 80,000 to 1.6 lakhs, ma'am, based upon the room that the patient takes.
Okay.
Yeah,
Okay.
I now request Dr. Asha Jain, ma'am, to please
Ma'am.
the program
It's
forward.
a very excellent one. Starting from the excessive show, she started from the excessive show to the embolization of the uterine artery and internal irrigator. Very excellent talk, and she has completed all the parameters and lab parameters, clinical parameters, starting from the topic, and very excellent. And I want to ask one question, ma'am. What is the incidence of abruption nowadays?
ma'am, I do not have any, what I have read are from the books, ma'am, and 0.5 to 1%. But I'm sure now with the ART and all these things, it has increased on one side. On the other hand, because of better management of cases of PPH and less of multi-gravidae presenting nowadays, it has decreased on the other hand. So I think it must still be in the same 0.5 to 1%. That is what I think. I don't know. Correct me if I'm wrong, ma'am.
Okay, thank you.
Thank you, Sujaya. Thank you, Deepa ma'am. Thank you, Narsavini ma'am. Thank you,
Any
Bharti
comment
ma'am.
from Dr. Sri Lakshmi, madam? One more chairperson.
Yeah, actually, madam is there, sir, but I don't know, ma'am is not.
Will I also see on screen?
Yeah, she's there, but I think maybe ma'am is busy otherwise.
Yes, Sri Lakshmi, madam. Anyway, we can proceed. Yes.
Yeah,
Yes,
Dr.
she's
Asha,
there.
ma'am, please. Yeah.
Thank you, Dr. Sujaya. So, Dr. Ramchandra has still not joined in, so we proceed forward to the panel, sir.
Oh, yes.
Okay. So my screen is visible, I hope.
Yes, ma'am, it's visible.
So the topic of our reverse panel today is consent. Is it something of concern? The expert is Dr. MC Patel, sir. I'm the moderator. And now I would like to officially introduce MC Patel, sir. I had just given a brief introduction. The sir is a consultant obstetrician gynecologist and medico-legal counselor. He was VP Foxy in 2018. He has organized the AICOG 2017 as secretary, chairperson, ethics and medico-legal committee Foxy 2011 to 13. Since 2011 to date, he is always available for every gynecologist 24/7, 365 days a year if they have any kind of medico-legal problem or they anticipate any problem. So thank you, sir, for that service that you are offering all Foxians. He is the honorary secretary of SOGO, organizing chairperson MMCon 2018, honorary member National Inspection and Monitoring Committee, PNDT. He's on many committees, many programs. He was the president of IMA Ahmedabad branch. But most importantly, he is standing for President Foxy this year. And as you all can see, you are part of the 189th edition. So consistency is there. He's consistent, he's approachable. And for the last 21 years, he's been going to the Northeast to serve the underprivileged ladies over there. He spends a week every year. And again, that has been going on for 21 years. So he's consistent and he's always there for each one of us. I welcome you, sir. And on behalf of sir, I would like to share a short video with all of you. That's me, and I've been introduced.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
Thank you, sir. So that is the vote appeal for election year 2024. Nominations will be in May and elections will be in August. Requesting all of you to please nominate sir from your society. That's me, and I'm going for chairperson for Drug and Medical Surgical Equipment Committee. Requesting nomination from your societies. And now we start with the panel proper. So I start with the first question as usual. Is this consent, which is so obvious, is it worth discussing?
Yes, of course, yes. Because there are so many cases decided in National Commission and in Honorable High Court and Supreme Court, and due to lack of consent or inadequate consent, cases were decided against doctor. So consent is a very important part in our day-to-day practice. And as far as Indian scenario is concerned, what should be the ideal consent in Indian context? Which are the criteria for any consent to be valid in eye of law? These are some areas as far as consent is concerned. And we are going to discuss all those areas one by one for today's webinar.
Thank you, sir. Now, The first question is to be asked by Dr. Shamshad Begum ma'am, who's the president of Anantapuramu. She's done her MD from JIPMER and has done training of trainers for Dakshata, Laksh, abortion care, and does a lot of trainings, also has a Best Doctor Award in 2019. Over to you, Shamshad ma'am.
Is she there or anybody can Anantapuramu can take?
Sir, can I read, sir? I am from
Oh
Kannur.
yes, oh yes, oh yes.
Sir, I am Dr. Venkatramana. Sir, what is agreement? What is contract? What is consent under Indian Contract Act, sir?
Yes. So, as far as agreement is concerned, when two or more persons agreed upon a same sense, that is agreement. And when it is enforceable by law, when agreement is enforceable by law, it becomes a contract. And for that, when persons involved in that contract signs the document, it becomes a consent. And under Indian Contract Act, Section 13, it is very specifically mentioned that two or more persons are said to consent when they agree upon the same thing in the same sense. So, if more than two and more than two persons agree for the same thing in a same sense with same mind, then it is called consent or contract. And as far as our medical fraternity part is concerned, as soon as any patient comes to our OPD and we becomes ready to treat her or we agree to treat her, then it becomes a contract between patient and ourselves. It is contract or implied contract. We are offering our expert services and patient pays for that or patient promises to pay for that. So this becomes a contract once we accept any patient to treat. Yes, next.
Thank you, sir. Now we have Dr. Sri Krishna Shashi, sir, and he is the secretary of Anantapuramu Society. He's an eminent personality in the field of obstetrics and gynecology. He was a pioneer in conducting buttonhole tubectomies and has done 1 lakh lap tubectomies. Great. He has the best doctor on district level 6 times and has been honored by IMA Anantapur. He also has the Foxy Dhira Award. Over to you, sir.
Sir, my question is, hello, sir.
Yes, welcome.
What is consent in medical field? What is valid consent? Which are the criteria for consent to be valid?
So,
this is my question, sir.
Yes, as far as consent in medical field is concerned, so voluntarily agreement or compliance or permission without any compulsion to treat is a consent in medical field. As far as any consent to be valid, there are certain criteria, and those criteria were decided by Supreme Court in 2008 in famous case of Samira Kohli versus Dr. Prabha Manchanda. And in that very case, Supreme Court came up with criteria that how any consent becomes valid in eye of law, or what is consent, ideal consent in Indian context. So first criteria is competence. Who can give consent? So that is competence. So any major patient who is adult, who is mentally sound, can give consent. If patient is minor, if patient is mentally challenged, then consent of guardian is required. So that is competence. Second thing, it should be voluntary. It should be for lawful condition. Say for example, if any patient gives consent to kill her, this kind of consent cannot be pardoned in eye of law or in court of law. So consent should be for lawful things. So competence, voluntary, lawful, it should be informed one. Patient should have knowledge about your treatment plan or about your surgery. So all the informed criteria we have to mention at the time of taking consent. These are some criteria for any consent to be valid. Yes, next.
Thank you, sir.
Next, sir, we have Dr. Nalini Katta, who's the consultant obstetrician and lab surgeon at Malikapuram. So her areas of interest are high-risk pregnancy, infertility, and laparoscopy. Does a lot of community work and has received Vishesh Seva Puraskar. So over to you, Nalini ma'am. I would
Good
request
evening.
you to please put on your video.
Good evening, all. Today, my question is,
Yes.
who can give consent? Can minor give consent for examination? Can she give consent for surgery or procedures?
So just I mentioned prior also little, when patient is major, more than 18 years, and when patient is mentally sound, then she can only give consent on her behalf. Nobody else can give consent on her behalf. So her consent is very much mandatory. As far as second question is concerned, can minor give consent for examination? Yes, if she is more than 12 years, or she is minor, less than 18 years, she is minor. But if she is more than 12 years, she can give consent for examination. Many times in case of POXO, in a case of sexual assault or sexual offense, when patient is brought to us and we have to take consent before proceeding anything. So if patient is more than 12 years, she can give consent for examination. But she cannot give consent for surgical intervention or any procedure if she is less than 18. So in this situation, consent of guardian is very much required. But at the same time, what is the word meaning guardian? Any person who guards the patient is guardian. But for guardian also to be valid for giving consent, guardian should be major. Guardian should be mentally sound. If somebody is accompanying her and she is also less than 18, then that person cannot give consent for surgical intervention. So in surgical intervention, guardian who is major and mentally sound can give consent.
Thank you, sir. Now we have Dr. Nirupama Palakodeti. She is from Osmania Medical College, consultant obstetrician and gynecologist at Sri Gautami Nursing Home, Bhimavaram. Over to you, ma'am. Nirupama, ma'am.
Good evening, sir. My question is, can
Yes,
mentally challenged give consent? Can a deaf and dumb person give consent?
So as far as mentally challenged patient is concerned, she cannot give consent. And in this situation, consent from guardian is very much required. As far as deaf and dumb is concerned, of course, she is deaf, she is dumb, but if she can read, then we can give a consent written. And if she is comfortable and if she understood, then she can give consent. One more thing in this type of situation, if we can arrange translator who can explain everything by action to him or her, and if she is agreed, then she can give consent.
Okay, sir.
Thank you, sir. Thank you, Dr. Nirupama.
Thank you.
Now we have Dr. B. Venkateshwara Rao. He's a professor and HOD at Kasturi Medical College and Hospital, Guntur. He is the honorary president of Guntur Obstetric Gynec Society. Welcome, sir. Over to you.
Good evening, sir, and good evening, everybody. Wish you all the best, sir, for your future endeavors.
Thank you, sir. Thank you, Venkat.
My questions are, who will give consent in case of emergencies? And second question is, what do you mean by informed consent?
As far as emergency is concerned, no consent is required. But burden of proof will be on your shoulder to prove that it was immediate necessary to proceed with treatment or surgery or any procedure. to save life of patient. So if this is situation, then you can very well proceed. But at the same time, your documentation should be very powerful to prove that it was an acute emergency and whatever you did, it was in good faith of patient. As far as informed consent is concerned, so patient should have knowledge about your treatment plan, about your surgery, with all its benefits and its side effects. And patient should have knowledge about total treatment plan. So it is informed consent. And we should explain everything to the patient related to its prognosis, its probable complications, outcome, and success rate. So when we explain everything about our treatment plan or surgery or procedure, then it becomes informed consent.
And I think it should be in the local language, not medical term.
Preferably, it should be in local language. But if it is not in local language, say for example, if it is in printed in English, then at the end of that consent, if she writes in her own handwriting that whatever written above was explained to me in language which I could understand, and then after I have signed, then it is okay. But in this situation, to be on safer side, if one translator is there who knows that local language, of course, consent is in English, but that fellow will read it and explain to the patient in her local language, and then after answering all the question on part of patient, if patient signs, then it becomes a valid consent.
Thank you, sir.
Thank you, sir. Sir, Dr. Umar Shankar, who's the secretary of Guntur Society, I
Yes,
don't
welcome.
think he has joined. So, sir, if you would please take this question as well.
So anybody from Guntur can take.
Yeah, I will take up, sir.
Oh, yes.
If anybody is there, okay. Otherwise, I will take up. I think
So
nobody.
please take up. Please take up, sir.
Yeah, thank you. First question is, does Supreme Court expect us to talk about all possible complications? Second question is, does Supreme Court expect us to talk about remote complications?
So no, in just I mentioned in beginning, in famous case of Samira Kohli versus Prabha Manchanda, Supreme Court has discussed this point also. And in that very point, Supreme Court has very specifically mentioned that one has to anticipate certain complications and requirement to deal with those complications depending upon the condition of the patient. And at the same time, Supreme Court has very specifically mentioned that no need to explain about very remote complication so that patient may be frightened and to give consent for necessary action. But at the same time, if patient refuses, then you have to explain about risk of refusal also.
Okay. Thank you, sir. Thank you, Rao, sir. Sir, next we have Dr. Padmalata Yarasi from Kadapa. She is the president of Kadapa Society. Ma'am, over to you. Ma'am, you are muted, please. Ma'am, you are muted. Dr. Padmalata.
So good evening, sir.
Yes, good day.
The question is, if patient or relatives refuse to give consent, what to do? Is there any role of negative
Ma'am,
consent?
please take the questions one by one.
Yeah.
So
If patient
yes.
or relatives refuse to give consent, what to do?
So we have to
Second one
explain
is-
patient
sir, tell me, sir.
in detail that why this treatment is very much necessary in that very given situation, why this procedure or surgery is needed, and even if she refuses to give consent, we have to explain risk of refusal. And at the time of explaining risk of refusal, again Supreme Court has come up with a guideline that no need to explain about theoretical risk or remote risk of consequences of refusal of consent. But we have to explain And after all this explanation, even patient is not ready to give consent, then we have to take negative consent. It is also very much important. Patient will sign that I had been explained everything, but I am not ready to give consent.
Sir, is refusal document and negative consent both are same, sir?
Yes. So if patient is not willing and if patient signs the document, so it becomes a negative consent that patient is not ready to give consent. But many a times, patient refuses to give negative consent also. Patient is not ready to sign any document. Whatever you have written in your counseling and communication in consent paper, patient is not ready to sign that I am not willing to give my consent, etc. So in this condition, to be on safer side, you can do two things. You can have a signature of any co-patient or any visitor of hospital, and they will write before us. Everything was explained to the patient and patient party, importance of this surgery or procedure or treatment, but they didn't give consent. So if we can do this, then it will be abundant caution in our favor, because whenever patients and patient relative are not complying, that it becomes a contributory negligence on part of patient. So it becomes good defense in our favor. But in this situation, word of caution, whenever you are going to take signature of co-patient or any visitor of hospital, then you please identify them with their full address and mobile number, and you explain them. If at all it is required to come to the court to give evidence in our favor, they should be mentally prepared. Because many times what happens, patient at the time of signing, they will give signature. But when they are required to be presented in court, then they will not turn up. So we should explain that part also.
If they refuses for negative consent, what can be done, sir?
I explained, no? You can have signature
we can
of
ask the
co-patient,
third party to
signature of
sign.
any other visitor.
Yeah. Yeah. Thank
We
you, sir.
have Dr. S. Venkatramana, President of Kurnool Obstetric Gynec Society. He has a special training in laparoscopic surgery, has more than 25 years of service in Kurnool Medical College. He is a KMC alumni, ex-president, IMA VP, member Safe Motherhood Committee, FOXY, Dhira Awardee, and Best Doctor Awardee. So over to you, Venkatramana, sir.
Thank you, madam. Good evening, sir.
Good evening.
Sir, can we allow attendee in the OT or labor room, sir?
So if patient is comfortable and if patient is giving consent, then we can allow.
So with taking the consent of the patient, then we can allow, sir.
Yes, patient should
Sir,
be comfortable for any person
okay,
to
sir.
be allowed.
But the attendee should not be visited by the other people, sir, because other patients are there, means we have to maintain the privacy of that patient.
Of course, that is why consent of patient is required.
Okay, sir. But the other patient should not be annoyed by entering the attendee.
Yes, if patient is not comfortable, if patient is not giving consent, then we cannot allow.
Okay, sir. Sir, can we record the surgery or the procedure, sir?
Very recently, one case happened before Supreme Court, and Supreme Court has referred this to NMC. And NMC has come up with guideline that you cannot record surgery, you cannot record procedure, and you cannot display live that very surgery in your conference. So till case is decided, it is guideline or circular on part of NMC, and we should be very careful.
But in the live workshops, recently we attended in Hyderabad also.
As on today, you cannot, because in one of the institution it happened. They were not aware of this NMC circular, and they went with this, and NMC has served a notice why you relay that live surgery. So in this situation, it becomes troublesome. So till this case, which is before Honorable Supreme Court, is decided, we have not to relay.
So what about now we have to conduct a live workshop or something?
So
like that?
if at all you have already planned, then in that OT, if patient is willing, then you can allow some 4 or 5 people to watch that live surgery. But you cannot relay or display that surgery in auditorium or in lecture hall also. As on today, it is totally banned by NMC.
Thank you, sir. Thank you, sir. So we can show it to the teaching class or CME. That also.
But again, by consent of patient only. And
Okay,
one
sir.
more thing you will have to observe confidentiality of the patient. So without this identity, I mean revealing identity of patient, and if patient is ready, then you can show to your student also.
Okay, sir.
But
Thank you, sir.
relay, I mean display, live display is totally banned as on today.
Okay, sir.
And before we proceed with another question, as far as Kurnool Society is concerned, this year Kurnool is going to bid for South Zone Yuva Foxy next year for 2025. So, our president and secretary are going to remain present at the time of managing committee meeting this
We are
week.
coming, sir.
At Calcutta, we have to support Kurnool.
Sir, thank you, sir. Thank you very much. Thank you, sir.
Thank you, sir.
Thank you, madam.
Next, we have Dr. Radha Lakshmi, ma'am. She is a professor of gynae at Shantiram Medical College, Nandyal. She is also the very, very dynamic secretary of Kurnool Society and is very excited about going ahead with this conference that they are planning. So over to you, Radha Lakshmi, ma'am. Ma'am, are you there?
Yeah.
Yes, welcome. Welcome, Dr. Radha.
Sir, good evening, sir. All the very best for MC Patel, sir, and Asha Jain, madam, for your coming elections. We'll support 100%.
Thank you.
And my question is, would you like to take separate consent for anesthesia? And if so, what should be explained?
Yes, we should have separate consent for anesthesia and all the points related to that very anesthesia, type of anesthesia, which how this anesthesia is given, what could be the effect of anesthesia, what could be the probable complication. We have to explain everything. And for this, anesthesiologist is the best person to counsel patient for anesthesia and explain everything related to anesthesia, and then patient will have to sign the document. But you have to simply visit Foxy website. On Foxy website, now it is available with title of Foxy Uniform Consent with 3 medical legal experts, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. Say, for example, for cesarean section, for hysterectomy, abdominal, vaginal, endoscopy. And in those 30 consent, we have prepared consent for anesthesia also. So you have to simply download those consent and you can use in your day-to-day practice.
So whether anesthetist has also to write everything about the anesthesia, what type of anesthesia is given?
Yes. I mentioned in that consent which we have prepared and which is available on Foxy website, consent for anesthesia. Everything is there. We have taken all the important points and we have taken based of famous case which I mentioned in prior also, Samira Kohli versus Prabha Manchanda. Whatever important points Supreme Court has suggested, we have taken into consideration all those points at the time of preparing those consent. Once you will go to that consent, you will appreciate that how much pain we have taken to prepare those consent.
Thank you, sir.
Welcome. Asha, you are muted. Please unmute.
Thank you, Dr. Radha Lakshmi, and thank you, sir. So, hoping to meet you soon. at Kolkata.
Okay,
Yes,
madam. Definitely, madam.
Now we have Dr. Ramakrishna Hanuman, sir. He's a consultant at Shankar Laparoscopy and Infertility Center, Chirala. He is from Ongole Society. So, welcome, sir. Over to you. You need to unmute yourself, sir.
Good evening, everyone.
Yes, good evening. Welcome.
Anyway, it's a very nice webinar. I thank you for making me a part of this program. And this is the first talk was on postpartum hemorrhage, and a lot of blood transfusion has been going on. Now, is there any consent which is required for blood transfusion in writing?
So, in one of the cases, court has very specifically mentioned that surgery involves risk, anesthesia involves risk, and blood transfusion involves additional risk. So, separate consent for blood transfusion is also required. So, if you are going to go for any surgery and if blood transfusion is planned, then you will have to go with 3 consent, one for surgery, one for anesthesia, and one more for blood transfusion. So it is very much required. As far as written consent is concerned, if we go by law, there are only 3 conditions where written consent is very much mandatory. One is organ transplantation, case of medical termination of pregnancy, and antenatal sonography in case of obstetric sonography or antenatal sonography, whichever we say under PCPNDT Act. Other than these 3 conditions, written consent is not mandatory, but burden of proof on our shoulder to prove that we had explained patient and patient has given consent. And if we have not taken written consent, patient may go hostile in court. So though it is not mandatory, but it is always advisable to go for written consent.
Is there any standard template for this consent form for blood transfusion?
Yes, I mentioned just prior. It is available on FOXI website. You have to simply go to FOXI Uniform Consent and you will download 30 different consent for cesarean section, for blood transfusion, for anesthesia, for hysterectomy, vaginal, abdominal, endoscopy, termination of pregnancy, medical method, surgical method, os tightening, transferring patient to higher center. We have prepared all those 30 different consent and it is available on FOXI website.
And is there any limit of hemoglobin for blood transfusions are legally? Like this much of like say 8 gram, 9 gram to substantiate the blood transfusion? Because there are people who state that 9 gram you need not transfuse blood.
In case of any bleeding condition, goal is to maintain hemoglobin at least by 8 gram was the discussion I hope in this lecture also. So we have to maintain that, and for that we have to plan blood transfusion accordingly.
8 is the limit.
Yes, not limit, but at least patient should have 8 plus, 8 and 8 plus.
Suppose somebody has 9 gram. Somebody has 9 gram hemoglobin, where you are planning to take care of a C-section.
If she is not bleeding actively and if she is having 9 gram of hemoglobin, you can treat her with oral medication also or parenteral also. But blood transfusion may not be considered in this type of situation if it is not an emergency.
Because oral iron and
in eye of law, Hanuman, in eye of law it is very clear. Whatever you do, you should be in a position to justify yourself in court. So you should have justified that whatever you did, it was as per standard textbook guideline given how to treat that very patient in that given situation, or standard practice prevailing in nearby medical college, or standard practice in peer group, or standard practice given in standard journals, or guidelines or protocol by, say for example, FOXI, ICOG, RCOG. If you have treated in accordance with this, then you are out of problem.
Okay, sir. Thank you, sir.
Yes, one more question was there.
That was answered, no, sir. Like,
Maybe. Last but one.
Can it be taken on a
pre-printed form? So in recent past, one case happened. RG Stone Hospital versus Dr. Vinod Khanna. Patient was HIV positive. He had some urological problem and surgery was needed. So many hospitals refused it only on the ground of her status of HIV positive. RG Stone Hospital became ready to admit her, to treat her. He was treated, he was operated, and in due course, he was discharged also. There was no complication. Everything was absolutely fine. But in spite of all this, he lodged a complaint against hospital that consent was taken on pre-printed form. And to take consent in pre-printed form is not valid and it is considered as an unfair trade practice. This was the allegation. Case was decided in favor of patient, surprisingly. And National Commission awarded compensation of rupees 10 lakhs. RG Stone Hospital was ready to pay 10 lakhs rupees. But at that time, we were preparing all those consents just I mentioned. So I, through Dr. Nikhil Datar, who was one of my partner in preparing consent, we approached RG Stone Hospital because we were interested to challenge that judgment. Because if this was not challenged, then it would have become routine that we were not able to take consent on pre-printed form. Either patient will have to write or surgeon who is going to operate will have to write. So we could conceive RG Stone Hospital. Otherwise, RG Stone Hospital was ready to pay 10 lakhs rupees to patient and to set out the matter. But we could convince on part of Foxy through Dr. Nikhil, and RG Stone Hospital preferred appeal in higher court. So at the time of tabling this appeal, our argument was, what is unfair trade practice? Unfair trade practice means any means taken in unfair way to promote business is unfair trade practice. If we take consent on pre-printed form, does it enhance our practice? If we take consent in patient's own handwriting, if we take consent in writing of surgeon, and if we take consent in pre-printed form, does it enhance our practice anyway? So, Fora was convinced and they admit our appeal. Still, it is to be decided, but we are quite hopeful that judgment will come in our favor. So this is very important case which happened with RG Stone Hospital versus Vinod Khanna.
Is there any
So
necessity?
as on today it is stayed. So as on today we can very well utilize pre-printed form.
Okay.
Because that judgment given by National Commission is stayed by higher fora, Supreme Court.
Is it necessary that consent to be in the local language, sir, or any other language?
If it is in local language, it is always preferable. But if it is not in local language, then just I mentioned prior also, we can have writing by patient herself that whatever written above was explained to me in language which I could understand. And after satisfying with all my questions and queries answered by doctor, I have signed the document. So if she has signed like this, then it is valid even if it is in English. And one more point we can go for abundant caution. And any other person who is translator, who knows that local language also, he can explain patient whatever written in our English consent paper. And if he signs that before me, everything was explained to that patient and patient was satisfied with all the answer given by doctor, and then after patient has signed the document before me, then it is very much valid even if it is in English or in any other language.
So thank you very much.
6 months prior.
Excuse me. It is my request to those who are not speaking. Please mute yourself. Please mute yourself.
Yes, next.
So next we have Dr. A. Sridevi ma'am. She's an associate professor at GMC Ongole, and she's got Best Doctor Award twice. So she's from Ongole Society. Over to you, Sridevi ma'am.
Sir, good evening, sir.
Good evening, welcome.
Sir, thank you, sir. Sir, one word I want to say for the previous question, sir. Sir, in all our case sheets in the government hospital, we have a printed consent form in that. That form only we are taking the consent from the patient, sir. It was written, sir. Consent form is there, sir.
So if patient is major and mentally sound, patient can sign document, no issue. If patient
Yes,
is minor or not mentally sound, then you have to take consent of guardian. And whenever you take consent of guardian, then your first question, who should sign the consent? So naturally, patient will sign the consent when patient is major and mentally sound, otherwise guardian. And there should be two witnesses. One witness in favor of patient, on part of patient, and one witness on part of hospital. And doctor should also sign the document, because under Indian Contract Act, unless all the party involved in the contract signs the document is not complete. And just I mentioned prior also, once we accept any patient to treat, it becomes a contract between patient and ourselves. It is implied contract. We are giving our expert services, and patient pays for that, or patient promises to pay for that. So under Indian Contract Act, all the party involved should sign the document. So doctor should also sign the document of consent. Yes, next.
Who can give consent for MTP, sir?
If patient is major, mentally sound, only patient can give consent. If patient is minor, guardian.
Yes, sir. Is the consent of spouse is required for sterilization, sir?
So there are two views. If we go with one case which was decided in Supreme Court, and that point of time Supreme Court came up with guideline that when you are going to go for full stop on reproductive capacity of that very patient, spouse should be taken into consideration, and consent of spouse should be taken. But in so many states, there are circular on part of government that consent of spouse is not required for sterilization operation. So if there is circular in your respective state, then you can go with sterilization operation without consent of a spouse. But if it is possible, it is always advisable, because many a time, not to end up into any legal problem, of course we cannot, but not to end up into any social problem. If spouse is taken into confidence, then it is always better. If he is not available, and if we can talk on telephone, it is also advisable that to have a phone call to him that we are going to go for sterilization operation on your wife, and are you ready? Are you giving consent? It's fine. Otherwise, if government circular is there, there is no requirement.
Okay, sir. Instead of Form C, can one take consent in usual manner as it is taken in any other surgery, sir?
So it is for MTP.
Yes, sir.
As per MTP Act 1971, to take consent in Form C is very much mandatory, because Form C is prescribed form, and we have to take consent in Form C. So, but Form C is simple form. I give my consent to terminate my pregnancy. So it is not informed consent, and naturally we have to go for informed consent also. So in case of MTP, we have to go with two consent. One informed consent, as we take in our usual any other surgery, and one consent in Form C. But consent taken in usual form, that is informed consent, cannot replace consent to be taken on Form C. So to take consent on Form C is very much mandatory under MTP Act 1971. Because if you do not take consent in Form C, and if something goes wrong, you may be triable under Section 313 of Indian Penal Code. So it is very dangerous one, because there is a provision of imprisonment for 10 years. So doing MTP without consent of patient. So we should take consent in Form C. It is very much mandatory.
Okay. So thank you very much, sir. Asha Jain, ma'am, sir, Patil, sir. Thank you, sir.
Thank you, ma'am. Thank you so much.
Okay,
So
ma'am.
now we have Dr. Parasarthi Reddy. He's the president of Tirupati Society, organizing secretary APCOP 2022, superintendent Government Maternity Hospital Tirupati, and professor Department of Gynae, SV Medical College Tirupati. He also has very many awards, and he's here with us to take you to the next question. Welcome, sir.
Thank you, madam.
Yes,
Good
sir.
evening, sir.
Yes, good evening.
Can one do salpingectomy with hysterectomy, sir?
As such, it has become now routine to go with salpingectomy with hysterectomy, but prior consent is very much required. So at the time of taking consent or counseling the patient for hysterectomy, we will have to counsel patient for that also. That if you are going to preserve ovary, not to end up into ovarian malignancy in future, it is advisable to go for bilateral salpingectomy. And if patient gives consent to go for salpingectomy, then we can very well go with salpingectomy. If patient refuses, then we cannot.
Okay, next question is consent required for obstetric sonography, sir?
Yes, under PCPNDT Act Section 5, subsection 1, it is very much required to have consent of patient for obstetric sonography also.
Excuse me, sir. May I ask something?
Yes.
Sir, in the F form, it is written that I declare that I will not ask the sex of the baby. But there is no consent for sonography per se.
So
there is no
yes.
consent. So do we have to take a separate consent?
Yes, exactly. So in Form F, that is declaration, that is not consent. And declaration on part of patient that I do not want to know sex of my baby. So this is declaration. So under Section 5, subsection 1, I have already mentioned, it is written that you have to take consent of patient, and in that consent you have to explain about probable side effect of your procedure, whether it is sonography, whether it is any invasive procedure or so. And for that you have to simply go with very simple consent. I undersigned so and so, give my consent to Dr. so and so for sonography, obstetric sonography. If everything is normal, I promise to continue pregnancy. I am not going to terminate my pregnancy. This kind of simple consent we can take. And we have to prepare in 2 copies. 1 copy is to be kept as our office record, and 1 copy is to be given to the patient. Copy of Form F is not at all to be given to the patient, because Form F is also to be filled in duplicate, 1 for our office copy and 1 is to be sent to appropriate authority at the end of month within 5 days of next month. So it is very clear in PCPNDT Act, but it is wrong interpretation on part of appropriate authority also in few of the district, that they will insist to go for Form F in triplicate. 1 will be given to the patient, 1 will be kept as a office record, and 1 will be sent to appropriate authority in due course.
Thank you, sir. Dr. Parasarthi, sir, would you like to add something to this? Or I go to the next question?
No, madam, after sir clears,
Thank you.
nothing will be there.
Thank you, sir.
Thank you, sir.
We are all with you, sir.
Thank you, sir.
Sir, is it necessary for gynec scan also consent?
No.
Pardon?
Hello?
Sir, is it necessary for gynecology scan also and follicular study also the consent?
By law, just I mentioned during previous discussion also, there are only 3 conditions where written consent is very much mandatory. 1 is organ transplantation, 1 is MTP, and 1 is obstetric sonography. Other than those, written consent is not mandatory. For gynec sonography, it is implied consent. Once patient, we explained that sonography is required. and if patient gives consent, I mean, is ready, and we are going to do sonography, and if we instruct patient to go to sonography table, and if patient goes to sonography table, it is implied consent that patient is ready to get that sonography of gynec. If we are referring that very patient to radiologist, and if patient goes to that radiologist, it is also implied consent that patient is willing to go for that gynec ultrasonography. So in this condition, written consent is not required.
Thank you, sir. Now we have Dr. Uma Devi with us, who's the assistant professor at Government Maternity Hospital.
Thank you, sir.
Yes, welcome.
And she is also the secretary of Tirupati Obstetric Gynec Society. Over to you, Dr. Uma. Dr. Uma.
Good evening. Good evening, sir.
Good evening. Welcome.
Yes, sir. Regarding this, my questions today are like, my first question is, can we do myomectomy during cesarean section?
Of course, we can do, but prior consent of patient is very much required. That at the time of cesarean section, I give my consent to go for myomectomy. If patient has not given consent for myomectomy, you cannot. Of course, if it is on the way to deliver baby, and even if patient has not given consent for myomectomy, then also you can go with myomectomy and deliver baby, and nothing to worry.
Okay.
But if it is not on the way, and if patient has not given consent, you cannot go with without consent for myomectomy. But if at all you have planned, if patient has given consent, then you should be readily available to deal with situation, because in gravid uterus, in myomectomy, we know that there is a chances of bleeding, and in this situation, we should be readily available to deal with blood transfusion also in nearby blood bank. So we should send a blood sample for cross matching, and blood should be ready in nearby blood bank so that we can deal with situation accordingly if at all it is required.
Okay, sir. But like in your experience, you do myomectomy, sir, along with cesarean section. Like
Yes,
you
I
encourage
do
that?
with, I have done so many myomectomy during cesarean section with prior consent of patient and with blood ready in nearby blood bank. It is my, of course, now I am doing very less obstetric practice. My major part is law practice. But when I was in full-fledged obstetric practice, it was my routine to send sample of blood for each and every patient on admission in nearby blood bank, and to keep ready 2 units of blood ready if at all it is required. Yes, next.
Okay, sir. My other question is, can we do tubal ligation along with cesarean section?
Again, if patient is willing, then we can very well do tubal ligation with cesarean section also. But few of our friends have a fear, because tubal ligation is national program. So if at all any complications happens, even if it due to cesarean section also, then it could be an issue for discussion. And for any reason, if there is death of patient, then it becomes a separate special inquiry, because tubal ligation is a national program, and media may cover in a different way in newspaper, etc. And it could be discussed in parliament also. So in this type of situation, legally we can very well go with tubal ligation with cesarean section if prior consent is given by patient, but we should be careful in this type of situation.
Okay, sir. But for that tubal ligation, both wife and husband consent is mandatory, no, sir?
No, just we discussed prior also. As such, it is not mandatory. In one of the cases, Supreme Court has advised that we should take consent of spouse. But in so many states, there are circular on part of government that consent of spouse is not required. So if you have circular like this, then you can very well go with tubal ligation without consent. But just in prior discussion, I also discussed to not to have any social problem. Legally, you are safe, but not to have any social problem. If spouse is approachable, even on telephone, he should be taken into consideration, taken into confidence, and then you should proceed for sterilization.
Okay, sir. The same question again, like consent of spouse required for medical termination of pregnancy.
For MTB, if patient is major, no consent of anybody, including spouse, is required.
Okay. Okay, sir. Okay, sir. Okay, sir.
Welcome.
Thank you, sir. Now we have Dr. Manikya Rao, sir. I was not able to read his name in the list, sir. Probably if
In
he has
beginning,
joined.
I saw him. In beginning, he joined, but I think
I don't.
anyway,
I cannot see him right
anybody
now.
from Kurnool. Anybody from Kurnool can take.
Dr. Radha?
Radha or Venkatraman, anybody.
They are both there. Anybody is requested to please take this.
Oh, yes.
Shall I proceed, ma'am? Is consent?
Oh, yes. Oh, yes. Oh, yes. Welcome.
Yeah. Is consent required at the time of advising for HIV testing?
So, as far as HIV testing is concerned, it is not mandatory, but it is guideline on part of NACO and WHO that you should explain about what is HIV testing, what could be its consequences, and before handing over the report, and especially when it is positive, you have to explain everything related to HIV and which are the treatment protocol if at all it turns out to be positive. Because in few of the cases it was happened, as soon as report was given to the patient that she is HIV positive, and she committed suicide same day. So in this type of situation, guideline from NACO and WHO that we should explain everything related to HIV testing, importance, etc. And if it is fine with patient, we should take consent of patient also. But by law, it is not mandatory.
So next we have Sir Dr. K. Sunita. Thank you, Dr. Umadevi.
Yeah, ma'am. Welcome, ma'am. Thank you.
She is the Vice President of Andhra Pradesh Obstetric Gynec Societies. And she is an MS from Tirupati, has 2 decades of teaching experience for undergraduate and postgraduate, has done many workshops, trainings, is the VP of APOX, Honorary Secretary APOX in the past, previously also Joint Secretary of Tirupati Society, has been chairperson and guest speaker at various conferences. Over to you, Sunita ma'am.
Thank you, madam. Thank you, Asha ma'am. Good evening, Patel sir. Am I audible,
Yes,
sir?
good evening. Oh, yes, welcome.
Good evening, sir. Thank you, sir, for your continuous and consistent efforts to educate our OBG friends in the field of medical legal aspects and helping us in many ways, sir. Thank you very much and my best wishes to you, sir. Today I was given, my question is video consent valid? What are the pitfalls of the video consent, sir?
So video consent is very well valid in court of law, but usually I say that video consent is double-edged sword. Because if you miss any important point for the discussion, then advocate on part of prosecution may take advantage of that very point, that you never mention that point, you never discuss that point. So your consent is invalid or incomplete. So of course we can go with video consent, but we should have a printed consent paper on our table, and we will see that no important point is missed at the time of counseling patient or communicating that very patient for that surgery or procedure at the time of taking video consent. So we can take video consent. It is valid in court of law.
Okay, sir. Can consent be taken by assistant doctor or a staff of one of our staff?
Yes, anybody can take consent, but whatever written in that very consent paper, all these points should be explained to the patient and patient party by assistant doctor or staff whosoever is taking consent. But
sir, it has to be signed by the chief doctor also after our assistant's signature.
No, anybody can take consent, no issue. Because in that case, Supreme Court has also mentioned it is not at all needed that person who is going to operate should take consent. It is not like that. Anybody can take consent, but patient should
Okay.
have understood all those points which are written in consent paper, and then after patient should have signed.
Okay, okay, sir. Can there be a common consent for diagnostic procedure and operative procedure
Yes,
together?
yes, we can. Say for example, if it is a case of primary infertility, and clinically, if we know that she is a case of PCOD, and if we are planning to go for ovarian drilling, that in those conditions, we can have a prior consent for both in the same consent for diagnostic and for operative procedure together.
Okay, sir. Can there be a common consent for particular surgical procedure and additional procedures that can be followed by that?
We discussed so many things: cesarean section with myomectomy, hysterectomy with salpingectomy. So we can go, but consent should be very specific for that. That patient should have given permission to go for myomectomy during cesarean section, or tubal sterilization at the time of cesarean section, or salpingectomy during hysterectomy or so. So if patient has given specific consent, then we can very well go with a particular surgical procedure and additional procedure also.
For example, sir, obstetric hysterectomy, after if PPH is there and you are following for obstetric hysterectomy, I think common consent is not valid in that case, no, sir?
No, Joe. Again, I would like to refer our consent which we have prepared and which is available on Foxy website.
Yes, I saw it, sir. It is very nice.
So, consent of cesarean section, we have mentioned, very specifically we have mentioned one paragraph that if any unanticipated incidence happens and if doctor has to go beyond the consent given by me, I give my consent to give consent in that very condition to Mr. or Mrs. So-and-so who is waiting outside operation theater. So in this situation, we will quickly discuss it with that very person. And if he or she gives consent, it is as good as consent given by patient. One more paragraph we have mentioned. In that we have specifically mentioned that if any unanticipated things happen and to save life of to save my life, if doctor has to go beyond the consent given by me, I give my full authority or full power to doctor to proceed accordingly in that very given situation. Then no need to discuss with relative also, and you can very well go with further. But again, burden of proof will be on your shoulder to prove that whatever you do or whatever you extend beyond the scope of consent given by patient, it was very much necessary to save life of patient, and you can prove it by your up-to-date documentation and records only. In this situation, you can involve your other professional colleague also, and if they have opinion that it is very much needed or required to go for obstetric hysterectomy to save life of patient, because before that you should have tried all your level-based oxytocin, ergometrin, prostaglandin, blood transfusion, stepwise devascularization, compressive suture. If you have tried everything, and in spite of all your efforts, bleeding is not getting control, and if you go for hysterectomy, it is always pardoned in court of law, because in court it is very much very specifically mentioned that to save life of patient, whatever you do and whatever you could justify that whatever you did, it was very much needed, then you are always pardoned and you are out of problem in court of law.
Okay, sir. Thank you, sir. I have a small doubt, sir. In Andhra Pradesh, Arogya Shri is there, sir. Have you heard of it, sir? A government program.
No, I have no idea.
Usually all the surgeries and everything are done free of cost in private hospitals, as well as they will government will give some fund to the government hospitals also. So when we are doing the procedures, we have to take the photographs of all the patients during the procedure also and after the procedure, and we have to upload it to the government.
But for that also,
how much justifiable it is?
For that also, you should have taken permission of patient prior, that I give my consent to record as per government guideline. I give my consent to record some kind of surgery, and then only you can record and upload to government. Otherwise, it becomes a breach of confidentiality.
Yes. Thank you, sir. Thank you very much.
But
So-
we are not taking any consent like that, sir. Excuse me, sir, Dr. Venkatramana.
But if at all we end up into any litigation, then it will
Sir,
be
sir.
very difficult for us. That is why it should be taken.
Yes,
So
I
they will
think
scan.
we have to do, sir, Venkatramana, sir.
Yes.
They
So
will do everything, scan and everything, and they will upload it in
Yes.
their case sheet.
Before we conclude or before we go with further discussion, it is my humble appeal to endorse
Sir.
my candidature for post of President Foxy. In month of May, first week, you will have a request mail from Foxy. Each and every president and secretary will receive it to go for nomination. So in month of May, you will have to nominate my candidature for post of President Foxy, and for Dr. Asha, Chairperson, Food, Drugs and Medico Surgical Equipment Committee. And in month of August, 1st to 10, election will be for office bearers, that is my election. And from 16 to 25, election will be of chairperson, that is for Dr. Asha. So on both of us, I request to endorse our candidature and to support our campaign. Thank you very much.
Thank you,
Thank you,
sir.
sir.
Thank you,
If
Patel,
time
sir, and thank
permits,
you, Asha, ma'am.
Yes. If
Thank you,
time
ma'am.
permits, we can
Thank you
have
so
some
much. So, sir,
Asha.
today we
Thank
are
you, madam.
almost on time.
Yes.
And
But if anybody have any one or two questions, then we will conclude very quickly, if at all. So if there is no question, then you can propose vote of thanks officially.
thank you, sir. Thank you so much. So I would like to thank Anantapurmu, Bhimavaram, Guntur, Kadapa, Kurnool, Angol, and Tirupati Obstetric Gynec Societies for participating in this webinar. I thank Dr. Aruna Bidupalli ma'am and Dr. Ramchandra sir to agree to be our chief guest. I thank Dr. Deepa ma'am for giving such a great lecture covering every point. I thank Dr. Sri Lakshmi, Dr. Bharati Chandrasekhar, and Dr. Narsavani for being with us as chairpersons. I also thank all the panelists. I thank all the delegates and also Corona Remedies for the educational support. I thank MC Patel sir to actually think of this program and run it. So at the end,
So
would like
I
to-
would like to have comments or suggestion from all the participants for this webinar so that we can improve for future webinar. If any suggestion, any comments, they can write to us in our WhatsApp group also. And we are going to put our this recording of this program in group only. You can display that recording in your further groups or in friends also.
Thank you so much. Namaskar. See you
Thank you,
again next Tuesday on another program. Thank
Thank
you
you,
so
ma'am.
much. Shubharatri.
And special thanks to Sujay Sri. Is she there?
No, sir.
No issue.
But Dr. Narsavani is there, ma'am.
Yes, yes.
So I'm ending the